My research is based on my thesis for my Master's in Clinical Science and Family Medicine program. And the genesis of the research was at a course where there was a bunch of family doctors and they were having a discussion about psychotherapy and family medicine. And there was about 8 to 10 people, from different experiences, all family doctors, and we couldn't come up with any definition of psychotherapy that was all encompassing. And so we thought, well, that's odd. We kind of know what it is, but we really don't know what it is. And yet we're all practicing it, and we know that family doctors see, at least 50% of their patients in a day can have mental health issues. The literature supports that psychotherapy is as useful, as effective, if not more, than pharmacotherapy or medications for depression and other mental illnesses. One of the factors that was actually conducive or helpful for family doctors to practice psychotherapy was collaborative mental health care. So those physicians, or family physicians I should say, that felt supported or were in an environment or in a group where they had psychiatric liaison, that had social worker, had psychologists to help support them in the work that they do, actually felt more confident and felt that their patients were better taken care of. So one of the needs that came out, and all the family doctors were kind of, there was consensus on this, was that yes, we need more training. Now the question is, where should that training come? Should it be undergrad, like medical education in medical school? Should it be during their residency, or should it be after graduation as a continuing medical education? We know that the longer that you study something and the earlier you know it, you can actually practice it more during your training. And so I think there was this sense that it should be taught well right from undergrad or in med school. So one of the things that, interestingly, some family doctors said that were helpful in them doing psychotherapy was setting aside time. So say, for example, half a day in a week was just, if that was set aside for psychotherapy, they found that, because it was dedicated time, they could then have patients come in for 30-minute sessions or whatnot. So instead of just sporadically doing it, to actually set aside time to be able to do it. But I mean, one of the other questions in this discussion is, do family doctors really need to do that much psychotherapy, right? When there are other people that might be well-trained or better trained to do it. For example, psychologists and social workers, for example, need to go, their training is really robust. They go through supervised, at least 700 to 1,500 supervised hours of doing actual formal psychotherapy versus counseling to be licensed to practice psychotherapy. And so do family doctors really have to do it? I think yes, in order for them to recognize the more knowledge they have, the better they will identify mental illness, the better they can support them in crisis, and be able to gauge whether or not a patient's actually a good candidate for therapy, and what kind of therapy. That most mentally ill patients will see their family doctors first. That's the first point of contact. So we truly are the gatekeepers. But I don't think necessarily that we need to be doing everything. We need to be trained enough to recognize, trained enough to support them in crisis, but perhaps after that, where for moderate or severe depression or other mental illnesses, if that can be delegated to people that might be more well-trained than us, including psychologists, social workers.